Right, hello everyone. So the second talk today is ECG and arrhythmias. I bought this pen yesterday. It was a £5 and it has one of these on it, so I will be using that. So the aims of this talk are effectively to go over ECGs. I realise you will have been over and over this in the past, but it's always good to practice. And also just to improve your ability at reading them, because ECGs, you can kind of get away with not knowing them 100%, and if you can work out what's going on based on what you can see on the trace, and I'll try and illustrate that tonight. And then there are some patterns that will come up on examinations, and if you're familiar with those, then you're sorted for any questions where you've got ECGs. So yeah, these are the contents. We'll start off really basic, and then just go through a few different rhythms, and there'll be a sort of interspersed quiz so that you can pretend that you're in a pub quiz if you so wish. So this is the conduction pathway. I suspect you'll have all done this since probably GCSE. So SA node, the impulse travels down the atrium to the AV node, and then down the bundles to the ventricles. That easy. And I found this on the internet. I was quite pleased with it because it shows the way that the impulse in the heart corresponds to the ECG, and this is how you can work out what's going on in an ECG if you can mirror up what's happening on the trace to what's happening in the heart. So the green bit is where the impulse goes from the SA node down the atrium, and that's the P wave. The red bit is the AV node, which is where you get your stop in the impulse, and then the ventricular contraction, the QRS, is this bit here when it comes down to the bundles. And that just shows systole and diastole. So diastole occurs between T and R, and systole between R and T. So these bits are rote learning really. You need to know normal ranges in order to be able to read an ECG. And there's not that much to know in terms of rote learning. It's just these three things really. So the PR interval needs to be between 0.12 seconds and 0.2 seconds for it to be normal. And if each small square on an ECG is 0.04 seconds, that means it's between 3 and 5 small squares. The QRS width needs to be less than 0.12 seconds, so less than 3 small squares. And the RR interval, which is your heart rate, should be between 3 and 5 big squares. And that's just a normal ECG. And the more normal ECG, it's the same as anything in medicine, the more normal that you see, the more obvious it is when you get an abnormal. So just get used to this trace. So things to look for. So this is coming up to what you probably did in third year, which is starting off with demographics and then going on to rate. So the rate is 300 divided by the number of small squares between the R's. There are a couple of other ways of doing it, but that's how I've always done it. Rhythm, you want to check whether it's regular or irregular, and then if it's irregular, is it irregularly irregular or regularly irregular? And then finally, is it in sinus rhythm? So have you got a nice PQ, RST sequence? Axis, a lot of people get very het up about axis. I think in clinical practice, it's not as important as it is in textbooks, but you need to know it for OSCEs in order to be able to talk about it if you're talking through an ECG. And I'll quickly go through axis tonight, but I won't spend any great deal of time on it. And finally, ischemia and infarction, because particularly infarction is the one thing you don't want to miss on an ECG. So going through axis. So basically what the axis is showing is the direction of the impulse. It starts off here and comes down here. So if you imagine it starts off at around the 10 o'clock point and goes down to about the 4 o'clock point. And that's just the direction of the impulse within the heart, if you imagine it going down like that. So that's a normal axis. And you get positive leads 1, 2 and 3. So if you see 1 goes that way, 2 goes that way, 3 goes that way. And where the impulse is pointing is sort of between 1 and 2, so you'll get positive deflections there. You might get a positive deflection in lead 3, but not necessarily. It's the same with AVL, but it's lead 2 that's likely to be the most positive. And you'll get a negative AVR, because if you see that's the opposite direction. If you imagine the impulse is going this way, AVR is right out here, so it's the complete opposite of where you're looking. And then in right axis deviation, the impulse is going this way. so kind of this way. And you can see that in pulmonary disease. So as a result, you get positive leads 3, AVF 2, and you might get the other ones as negative. So for instance, AVL, AVR, you can get AVR. Well, AVR will become more positive if you see, because it's gone from there to around there. And then left axis deviation is the opposite. So the positive leads are going to be 1, AVL, and then the negative leads are going to be these ones around here. So if you're analysing an ECG, you want to think about the following things. Firstly, is it fast? Is it slow? Is it irregular or is it regular? Are there P waves? Have you got nice QRS complexes, and are they broad or narrow? And is there any ST derangement? And if you can answer all 5 of those questions, you're probably going to be able to diagnose whatever's on the ECG, because that should cover just about everything really. So if we go into some arrhythmias, so atrial rhythms. The 2 atrial rhythms we'll be going through tonight are atrial flutter and fibrillation. So atrial fibrillation is really common. It's about 5 to 10% of 65-year-olds have AF, and when you get to people of the age of about 80, roughly 20% have AF. And the reason so many people have it is there's loads of causes of it, and the causes are quite common. So the causes are ischemia and infarction, and then hypertension as well. If you think about how common hypertension is, it's a big risk factor for AF. And then other diseases as well, such as hypothyroidism, respiratory diseases, and alcoholism. And then the symptoms. So if you think about your heart, if your atria is doing weird things and your heart's doing weird things in terms of an irregular pulse, it's going to feel very uncomfortable. So you'll get chest pain and you'll get palpitations. And also your cardiac output drops, which can make you feel really tired as well. And the reason we're so bothered about atrial fibrillation is that the complications of it are potentially really serious. So stroke, acute heart failure, cardiomyopathy, and particularly stroke. So looking at what we're looking at now, atrial fibrillation, it's all this area here that's affected. It's the P wave. And on the trace, we'll be looking particularly at this part of the trace. So what causes it? Well, basically, you end up having small areas of the atria setting off impulses rather than one coordinated impulse going through the heart. So you end up having little specks, which are these little white things here, going off. And it's often described as being like a bag of worms, just moving like that. And the reason you get an irregular pulse, which is kind of the hallmark of AF, is that these impulses won't all cause a QRS. So what I mean to say is that some of these are going off all the time, and dependent on what the AV node's doing and what part of the cycle it's at, some of the impulses will be brought through to the ventricles and others won't. So it's kind of at random, and you can see that on the trace. You get this random irregular pulse, no rhyme or reason to it. So the rate can be anything really, dependent on how many impulses are taken through to the ventricles. The rhythms are regularly irregular, as you said. There's not any P waves, but there is atrial activity, because the atria is doing something, but it's not doing anything in a coordinated fashion. And your QRS complexes are narrow, and that's really because the anatomy of the ventricles is completely normal. So once you've got past the AV node, everything's normal. So you have to stratify AF into different categories. Does anybody know why you have to stratify AF into categories? Yeah, so basically what it is in terms of management, how are you going to manage the patient is dependent on what their AF's like. Now, around half of the population will have a period of AF in their lifetime, so it's really, really, really common. But that doesn't mean that half of the people in the population will need treatment for AF. So loads of people have one undiagnosed or diagnosed episode of AF, in which case you probably don't have to do anything with those people. It can just happen as a sort of weird and wonderful variant of your normal heart rhythm, and then never come back again. Paroxysmal AF is a bit more, there's a bit more of a weight to it because you're getting recurrent episodes, but these episodes aren't lasting for a particularly long period of time. They're lasting for less than 7 days. Persistent is when you get recurrent episodes, but they last for a long time, so more than 7 days. And then permanent is just if you've got AF all the time. So the management, first of all, one thing you can do is try to remove any reversible cause that might be causing the AF. And then you need to decide whether to go for rhythm control or rate control. Does anybody know why you would choose one over the other? Can anyone give any reasons as to why you would choose one over the other? Yeah, age is a big thing. So in older people, would you go for rhythm or rate control? Yeah, because basically when you're older, it's harder to revert back to sinus rhythm. So yeah, so that's a good reason. And then the second thing is the type of AF that you have. So stratifying it early was actually really useful because it's guided how we're going to manage these patients. So if you've got permanent AF, your chances of reverting back to sinus rhythm are relatively slim, and it's not really worth going down that path. So you go for rate control. But if you've got someone who's just, having an occasional burst of AF that lasts a short period of time, you can actually go for rhythm control, particularly if they're young. And the way you do that is with these ways of doing it. So flecainide is this pill in the pocket thing. The idea being that you can just keep the pills literally in your pocket, and then if you have the symptoms of AF, pop one of the pills, and hopefully you'll revert back to sinus rhythm and the symptoms are gone. So that's a really effective way of treating it if you've got paroxysmal AF. And then more sort of hardcore ways of dealing with it. So direct current cardioversion and amiodarones, antiarrhythmic treatments that you can use. And you also give a beta blocker, so you can give sotalol, and anticoagulation as well. We'll talk a bit more about anticoagulation in a minute. And then in terms of rate control, beta blocker and calcium channel blockers are the first line, so you would give one initially rather than both. And then you can give digoxin if they don't work. And again, anticoagulation is really important. Does anybody know the score you use for deciding what type of anticoagulation you're going to use? Very good, yeah. So there's two. There's CHADS-2 and there's CHADS-FAST. And my understanding is that initially you can do your CHADS-2 score, which is a sort of simpler version. I think the H might be wrong. I think it's heart failure rather than hypertension. But basically, you score people a point out of 6 for each one. And if you score 0, you can get away with giving aspirin. If your score's 1, you probably need to discuss it. And if it's 2, you need to give warfarin. So it's a relatively low threshold for giving warfarin, and that's because the risk of stroke is high. A score of 1, so aspirin or warfarin, you need to discuss it with the patient. It's a ball ache being put on warfarin, so ideally you do want to avoid that if possible. But then again, if you've got someone who's 74, for instance, next week they might become 75, in which case their CHADS score will go up. The other thing you can do for a patient who has a score of 1 is do this CHADS-FAST that you were talking about before. Again, the H is heart failure rather than hypertension, I think. And that can be used for people with a CHADS-2 score of 1 to stratify a bit more as to whether they should be on aspirin and warfarin. But in general, it's a fairly low threshold for starting warfarin. Flutter. So the causes of flutter are really quite similar to the causes of fibrillation, apart from there's a bit more to do with the structure of the heart. You can get flutter with structural abnormalities and with heart surgery. Particularly a week after heart surgery is prime time for getting atrial flutter. 30% of cases are idiopathic, and there's also association with non-steroidals. The symptoms are very similar to those seen in atrial fibrillation, and the complications are very similar. The only added complication is that you can get long-term AF as a result of flutter. So what's happening? So if you imagine the SA node up there, and it should be going from there to there and nicely down there. But in this case, you end up with this circulating rhythm around the atria going like this. And again, some impulses will be sent down the AV node and others won't. But that's what's happening. You're getting a circular rhythm around the atrium. And the rate tends to be a multiple of 75. And that's to do with the speed at which the impulse goes around the atrium. So It's either could be 75, 150 and 300. This is a really useful thing to know for exams, because if you see a trace that's 150, you can start to be suspicious of what it might be. The rhythm is regular but can be variable sometimes, but the main thing to see is this sawtooth baseline. So as you can see, it's a very consistent baseline. And if you remove the QRSs, as is done here, then you can see that it's very consistent, the wave that you can see. QRS complexes are narrow. Again, if you think about the structure and the anatomy of the ventricles, it's exactly the same as it would be in a healthy person, so that's just the same. Management, same thing again. You want to treat the underlying condition. If they're hemodynamically unstable, you need to do something quick, particularly if the rate's 300, for instance. So you can do urgent rate control and cardioversion. And then again, you want to stratify in the same way that you did with AF, in terms of rhythm control or rate control. So rhythm control, you can do catheter ablation, which is basically, down here you can see, you basically cut off an area of muscle where the impulse is travelling, so that you end up blocking off that circular rhythm. So you basically fry part of the muscle in order to block off that circulation. And then the thinking then is that you'll then go back into sinus rhythm because the impulse will pass through the atrium normally. And the other thing you can do is cardioversion, either electronic or with pharmacological therapy. And rate control, calcium channel blockers are first line, and then beta blockers are amiodarone second line. And again, thinking about anticoagulation in the same way you did with AF. So, okay, so if we quickly go through the answers to the quiz, that's everything in terms of the lecture. What's the rate here? Just shout out the answers. 72? 72, that's very accurate. Yeah, about 75, yeah. And what's the abnormality? Yeah, ST elevation where? Yeah, there you go. Question 2, what's the rate? Yeah, sort of 40, 45, yeah. And the rhythm? Yeah, sinus tachycardia, sinus bradycardia rather. You've got a P, you've got a QRS, and you've got a T, but it's very, very, very slow. Anyone brave enough to think they know all three? Hands up. Yeah? No. No. Good try. Oh, hold on. Anyone else? No? Ukraine, Turkey are both correct. No, I think that's Hungary. Austria and Hungary, yeah. So, okay. Next question, what's the rate on this one? $100, yeah, so it's about 3 squares between each take 100. What's the rhythm? Yep, sinus tachycardia, very good. Anybody do this? Anybody had the... Yeah, very good. What do you do for this one? Any ideas? So first thing you want to do is, if this is VT, you want to check the pulse, and then you want to do all your compressions and shocking if they've not got a pulse. But effectively, you don't want to be dealing with this on your own. Anybody? First of all, what's the category? Oscars, yeah, best picture. Anybody know the answer? Oh, I heard it. Who's that? Yeah, very good. Very good. Slumdog Millionaire. This one? No. Good effort, but no. So this is complete heart block. You see all waves just sort of at random points. There. So that's complete heart block. Bradycardia. I've not heard it yet. 5-1. She's very small. She's very, very small. And then finally, what was, left bundle branch, but very good. In summary, ECG recognition is a mixture of pattern recognition and being able to visualise what's going on in different parts of the trace. The traces are quite often in the slide exam, and recognition is really important clinically. Has anyone got any questions? No, unless they're being really cool. Thank you.